Good morning, friends. We are today going to go through a very important topic, acute respiratory infections. Very important from the point of view of the fact that most of the OPDs which you will see once you graduate from here, you will find children coming in with acute respiratory infections. Not only once. It is generally said that approximately in our country, every child gets 4 or 5 bouts of acute respiratory infections per year. So just imagine, if a person ran his OPD only for acute respiratory infections also, he would be getting a huge number of cases. Let's see what we have in epidemiology. Well, infections which cause inflammation of the respiratory system anywhere from the nose to the alveoli should be considered as acute respiratory infections. And so we will be considering acute respiratory infections in 2, 3, 4 categories. And please remember, this is only one topic which we are considering about acute respiratory infections. You must read up about IMNCI, that is Integrated Management of Neonatal and Childhood Infections, which is a very important topic. We will possibly take it sometime later, but if we miss out that, please read up. It is very, very important to remember IMNCI and how it is being dealt with in our country. So upper respiratory infections can be sinusitis, common cold, pharyngitis, epiglottitis, laryngotracheitis, and if it is the lower respiratory infections, we can talk about bronchitis, bronchiolitis, pneumonia. Now, ARI is responsible for almost 3.9 million deaths every year. 6.8% of the worldwide deaths are due to acute respiratory infections. And more of this concentration is in our lower income group of countries, especially in Bangladesh, India, Indonesia and Nepal together, which constitutes about 40% of the global mortality. So that is the amount of incidence of disease which we have, and we require to put in a real effort to control it. The incidence in developed countries, if you see, is just about 3 to 4%. But in developing countries, you find almost 20 to 30% of the population would get an acute respiratory infection. And to add to it, the deaths due to pneumonia of children less than 5 years, children below 5 years, is very large in developing countries. If a child gets pneumonia, from the total number of illnesses which we have, 20 to 30% is due to pneumonia, and we have to look into this, try and control this particular disease. The acute respiratory tract infections are the most common cause of morbidity. The greater the degree of morbidity and mortality is in the extremes of age, that is, as I mentioned, below 5 years, and also among the elderly. People above the age of 65 years have more chances of mortality when they develop an acute respiratory infection. So, in children, we can actually group them into below 2 months of age and 2 months to 5 years of age. Any child below 5 years does have a chance of getting acute respiratory infection, but a child below 2 months getting an acute respiratory infection can be more of a problem. The old and debilitated, as we grow older in age, we have a problem of immunity. The immunity goes down, and that is how even today when you're looking at COVID infections, you find that the death rate is higher among those individuals who are above the age of 65. We also talk of comorbidities in case of COVID infection. What is comorbidities? What are they talking about? The comorbidities will lead to a decreased immunity. As such, a person who is above 65 years, his immunity is down. When the comorbid conditions also decrease his immunity, and hence old and debilitated are the ones who lose their life in most illnesses. Immune suppressed individuals, of course, these people are the ones who will definitely suffer more problems. Now, as I mentioned, management of ARIs in children has been particularly highlighted with the WHO. They have a program called IMNCI, which is in India has been modified so that it's very useful as far as control of pneumonia, the respiratory disease, and what is the second other disease which is most common in children? Diarrhea. So diarrhea and respiratory diseases. These are the two most common diseases in children, and that is the reason why we have targeted in IMNCI these two diseases for control. And we have IMNCI does have now another breakup which is called FIMNCI, that is faculty based IMNCI, which is really as to how you will deal with IMNCI when a child is admitted to hospital. We'll talk about IMNCI as we go by. So as we mentioned, acute respiratory infections, mortality is high among the children below 5 years. Okay. The main reason for health consultation and hospitalization in the developing world, if you look at it, 13% of inpatient deaths in pediatrics wards are due to acute respiratory infections. About 30 to 60% of medical consultation is due to acute respiratory infections. 20 to 40% of hospital admission for children below 5 years is due to pneumonia. So that is how important this particular condition is. It's also the main reason for drug prescription in children. In most of the cases, these drugs which you give, maybe if a child comes with a running nose with a little bit of fever, and the first thing that the physician does is give antibiotics. Is it required? It generally is unnecessary, potentially dangerous, and may stimulate bacterial resistance and increases the cost without benefiting the patient's health. So when is it necessary? When is it not necessary? We will consider this in this particular lecture. The majority of cases of pneumonia in children in countries with high infant mortality rate, our countries with a high infant mortality rate, is from Streptococcus pneumoniae and Haemophilus influenza. These two diseases can be very easily treated with inexpensive antibiotics. Can you think of which is the most inexpensive antibiotic which is available? Something which we have generally forgotten and which is hardly used nowadays. Well, it's penicillin, and that is what we will use, or we'll use some other medicines which are similar to penicillin. Viral pneumonia requires to be differentiated, and okay. So this is the number we have. I already mentioned H. influenza and Streptococcus pneumoniae are responsible for maximum deaths in children below 5 years. Let us consider all the agent factors. There are so many, numerous, which includes bacteria, viruses, and others. Within the species also they show a wide range of antigenic diversity. Have you ever thought why is it that we do not have a vaccine for common cold? You see, any vaccine which is produced, if you produce a vaccine, it should be of a single antigen, or maybe 2 or 3 or 4. You cannot produce an antigen for a disease which has 155 antigens, or 165. Common cold has 165 different varieties which are there. And that's the reason why we have not been able to make a vaccine for common cold. Okay, that is just in passing. In case of viral infection, severity of illness depends on whether secondary bacterial infection takes place. Well, that's what it is. You see, common cold, you don't find people dying of common cold. But if there is secondary bacterial infection which takes place and the person then goes into pneumonia, then you can have patient dying. Okay, let's see the list of the organisms which cause this disease. Streptococcus pneumoniae, which causes Streptococcus pneumoniae, Legionella, pneumophilia, Klebsiella pneumonia. These are all in adults. Streptococcus pneumoniae comes in children also. Staph pyogenes, Streptococcus pyogenes, and these are in all ages. And Hemophilus influenzae, which in children causes epiglottitis, in adults causes pneumonia. Montella proteus, we have already discussed it last time, where children causes cough. Corynebacterium diphtheriae, which causes nasal and tonsillar or pharyngeal diphtheria, we have already discussed that. Among the viruses, we have rhino and coronavirus. We are nowadays talking a lot about coronavirus. This size was made much before COVID, by the way. And so, we always had coronavirus. It's only that COVID has come in, so we are now talking a lot about the various coronaviruses. The coronavirus, rhino and coronaviruses have been known to cause common cold and influenza. Adenoviruses, which cause pharyngitis. Respiratory syncytial virus, which causes bronchiolitis and pneumonia in children. Parainfluenza virus, which causes croup. Influenza A and B, we already discussed that, causing influenza-like symptoms or can cause even pneumonia in the elderly. Enteroviruses, yes, enteroviruses can, though enteroviruses are, what are enteroviruses? The E. coli or the Coxsackie viruses which are there, these are the ones which can cause acute respiratory infection. Measles we have already discussed, which is a paramyxovirus. Chlamydia type B, Coxiella burnetii, and Mycoplasma, these can cause atypical pneumonia and bronchitis. What are the host factors? Well, as we mentioned, the extremes of age. Either the very young, that is children, infants, young children, or the elderly. But there is another group of individuals who does get infections, that is, in the third decade of life you have more mothers. So these mothers who are close to their children who are infected, they are the ones who do develop the disease. As far as sex differentiation is concerned, under 3 years you have boys which are more affected. In adults, the women are more affected because of the fact that, as I mentioned, they are closer to the children, so they get infected. Winters are the months when acute respiratory infection is at its peak. Also, we do have a small peak which comes on in the monsoons, which will come now shortly. We'll be having the monsoons. We'll get a few cases of acute ARI at that time also. Overcrowding, any disease which is transmitted by the oral route, which is by droplet infection, will be transmitted, which will have it's more during overcrowding. Attack rates are high in close-knit populations, like in schools, colleges, other institutions. In community-based studies, boys appear to be more affected than girls. There was the various studies which are there. In one of them in Brazil, we found a male preponderance inversely related to age, whereas 74% of the cases under 6 months were boys. If you look at mortality is more among infants. Half of the deaths of children below 5 years. Rather, if you're looking at below 6 months of age, the mortality is even higher. Well, the lower socioeconomic group, you have more problems. The reason is nutrition is poor, immunity is poor. Parental education, lower the education, more is the ARI and mortality. Place of residence, ARI incidence varies markedly between urban areas and rural areas. In urban areas, you've got 5 to 9 episodes, while in rural areas where there is less of overcrowding, you have 3 to 5 episodes. Exposure to smoke, again, so people who have, if there are sources of smoke, etc., these children would get more problems, atmospheric pollution, domestic biomass pollution, or passive smoking by with the children with the maternal smoking taking place. Children of smokers show about 1.5 to 2 times greater incidence of ARI than those of non-smokers. And overcrowding, as we already mentioned, exposure to cold and humidity is also considered one of the environmental factors. Any low birth child has poor immunity, so the chances, greater risk of 1.5 to 8 times of the child getting the infection. The reasons are that possibly the lung function, preterm lung function is not very good, also decreased immunity. Malnourished children, as I mentioned, the immunity is low. Those children who do not have breastfeeding, again the immunity is low. The deficiency of vitamin A also has been noted to cause more chances of ARI. Deficiencies of micronutrients. Behavioral factors, these factors are likely to influence. You see, the main this thing is you look for patterns of child care, where the children are maybe in creches or we have overcrowding, we have chances of more infection. Well, remember that ARIs are transmitted by airborne route and direct person to person. I think I don't need to elaborate on this, especially in the COVID environment. Everybody knows more about it through Google than I will be able to tell in the class, so you can very much look it up about airborne transmission. Acute respiratory tract infection can be either in the upper respiratory tract or lower respiratory tract, as we mentioned earlier. Common cold, pharyngitis, epiglottitis, laryngotracheitis, these are the upper respiratory. Lower respiratory being bronchitis, bronchiolitis, and pneumonia. Now, what happens as far as the pathogenesis, like for example in common cold? The infected virus is transported to the adenoid area, where they bind to the intercellular adhesion molecule, one which we also call CD54. They replicate within the respiratory epithelial cells. This is a differentiation between viruses and bacilli. Viruses will replicate inside the cells, and they will activate an inflammatory cascade. You know about various things nowadays. A lot being talked about the cytokine storm, etc., which does take place, and we have. I cannot discuss the cytokine storm in detail over here. Please read up about it. It's very interesting as to how we have problems which occur due to the cytokine storm, especially in the COVID environment. Clinical symptoms occur within 10 to 12 hours. And in the common cold, you normally have a sore throat, profuse watery rhinorrhea, watering of the eyes, nasal congestion, sneezing, and cough. If there is complications or there is superadded bacterial infection, one can have middle ear infections and sinusitis. In pharyngitis, you have bacterial virus which is involved, which invade the pharyngeal mucosa and will create a local inflammatory response. Some of these viruses can cause irritation of the pharyngeal mucosa, and this results in a sore throat, fever, headache, swollen lymph nodes in the neck, running nose, a post-nasal drip, which is the main reason for the cough which takes place, dysphagia and dyspnea. Okay, yeah, here it is. I was just looking, 2 what's the difference between odynophagia and dysphagia? Dysphagia is difficulty in swallowing. Odynophagia is painful swallowing. Painful swallowing is odynophagia, where dysphagia is difficulty in swallowing. Okay, so epiglottitis is basically the acute inflammation of the epiglottis, valvular, or the epiglottic folds and arachnoids. So we have sore throat, odynophagia, dysphagia, fever and mild cough, stridor and muffled voice. The complications can be with the superadded infection can be otitis media, adenitis, and cervical necrotizing fasciitis. In laryngotracheitis, basically, what is also known popularly as croup. As the infection extends to the proximal trachea, diffuse inflammation with exudate and edema of the subglottis can take place, which can result in narrowing of the airway, and that's the reason for the typical sound in croup. A small amount of exudate in this region can cause significant airway obstruction. Airflow in this narrow subglottic area causes stridor, which is medical emergency. So what will happen? You'll have, since narrowing of the passageways, so you'll have brassy ceiling, barking cough, low-grade fever, and stridor, which can occur. Complications are respiratory failure. What occurs in bronchitis? Viruses or bacteria cause inflammation of the respiratory passages, which result in irritation and cough. There is mucus production, so there is phlegm. The swelling of the mucous membrane of the bronchi along the production makes, you see, there's narrowing of the passageways of the bronchus, so there is a wheeze. The persistent cough, sputum, burning pain, wheezing, crackling in the chest, painful and difficult breathing, malaria and low-grade fever, insomnia. Complications are right-sided heart failure, cor pulmonale in chronic cases, emphysema and pneumonia, and pulmonary hypertension. Bronchiolitis, bronchitis is the infection of the bronchuses, while bronchiolitis is a small bronchioles. It goes in, infiltrates into the epithelium, proliferation in the globulate cells, and there is excessive mucus production. Lymphocytic infiltration with submucosal edema can occur. The obstruction of the bronchiole by the inflammation, edema, and debris can cause hyperinflation and atelectasis. Basically, when you have the bronchus and bronchioles constricted, the passageway, the air passage will not be possible. And once there is, the air cannot be, in expiration, the air that cannot come out, the air has to go somewhere. That's why there is hyperinflation and atelectasis. The symptoms initially may start off as a coryza or congestion, low-grade fever, but later will go into cough, dyspnea, and wheezing. What is more important is pneumonia, where anatomically we can divide into lobar pneumonia, bronchopneumonia, or interstitial pneumonia. Microbiologically we can have it as bacterial pneumonia, or viral pneumonia, fungal pneumonia, or parasitic pneumonia. And clinically we can have two types, that is community-acquired pneumonia or hospital-acquired pneumonia. So we already discussed this pathogenesis, where we had viral replication inside the cell and the spread which takes place resulting in cell death and an exudate. While in case of bacilli, there is the bacterial multiplication takes place in the lumen, and toxins and enzymes are the ones which can cause cell death and the exudates. Oh well, this is nothing very great. The normal alveoli, and here also you can nothing to do. You have seen this in pathology, where we have pneumonia, lobar pneumonia, and bronchopneumonia. I will not go into the details of this. Okay, community-acquired pneumonia. This is an infectious pneumonia in a person who has not recently been hospitalized, and we are looking at Clinical features of productive cough, high fever, diuretic chest pain, and shortness of breath. That is in cases of major problems. Initially, the patient just comes with fever or loss of appetite, fatigue, may have vomiting, may have joint pains. So you require, especially in children, and especially when you're talking about, we will be talking, we're not talking in this lecture, but later on, as I mentioned, in IMNCI, we need to grade the children into the 4 groups of very severe pneumonia which is not severe, or no pneumonia. Basically, this is required because of the fact that we will be having different modus of treatment, especially children who have pneumonia or who have other upper respiratory infections can be treated at home, while children with very severe pneumonia or severe pneumonia require to be hospitalized. Very severe, we're taking it from the highest grade to the lowest grade, so bear with me. The very severe pneumonia cases are unable to drink, may have convulsions, may be abnormally sleepy. You're looking at a toxic child. You may have stridor in a calm child, and maybe with severe malnutrition. But the classical features which we have to consider whenever a child comes with pneumonia, look at the breathing. Breathing is the most important portion to be looked at when you see a child with pneumonia. Is the respiratory rate below 40? Is the respiratory rate below at 50? So what we are looking at is the breathing of the child, whether the child is having a respiratory rate which is below 40 or not. If a child has got a respiratory rate which is below 40, then we are not looking at something which is very, very serious. Any child which has got a breathing which is above 40, then we have to start looking at if the child is having a breathing, if the child is between 2 to 12 months old and the respiratory rate above 50, then we are considering a case of severe pneumonia. If a child is 12 months old, then a respiratory rate of 40 and above, we are looking at severe pneumonia. So that's the cutoff point which we look at. So the other things in severe pneumonia is indrawing chest, fast breathing, a nasal flaring or a grunting, and a cyanosis. In other cases where you have cough or cold where the breathing is normal, you do not really have to bother. Not that you don't have to bother, you don't have to be severely concerned. We'll talk about it. The complications of pneumonia are respiratory and circulatory failure, pleural effusion, empyema, pneumothorax, and abscess. And I hope all of you are able to diagnose these clinically. We have taught this in clinics, so please read up. If you have not read, please pick up your Hutchinson Hunter to make out how will you differentiate between an abscess, a pneumothorax, an empyema, or a pleural effusion. These are things which you should be able to make out whether there is a consolidation or not, whether there is you should be able to make out whether there is a rub which is there, or whether there are rhonchi. All these things you should be able to clinically make out. The various things are given in Hutchinson Hunter. Please read up, and we will talk about it when we meet in the clinics. Now, what is the treatment? As we mentioned, history taking is very important. The age of the child or the person, duration of symptoms, food and water intake, what is the activity of the child, whether the child has convulsions or not, altered respiratory habits, and The respiratory habits, as I mentioned, most important is the breathing. First is the number of counts. Second is whether the child is irregular breathing. Third is whether the child has got stridor. And if it gets worse, the child is sometimes unable to breathe. And once the child is unable to breathe and is you find that the oxygenation is not complete, you might have cyanosis suffering. So as I mentioned earlier also, we decide on the basis of respiratory rate. We cannot overemphasize on this. Respiratory rate. In children, look at respiratory rate, most important. So you divide, as I mentioned, you're looking at 40, 50, 60. 40, 50, 60. 40 for children 1 to 5 years old, that's the older children. 50 in 2 months to 1 year, and in less than 2 months you're looking at 60 per minute. So look at it, 40, 50, 60, very easy to remember, 40, 50, 60, and please remember this when you're checking for respiratory rate. Chest indrawing, look for chest indrawing, stridor, wheeze. Any child who is excessively sleepy, you have to get concerned about a child who is excessively sleepy. Look at this child, maybe he is toxic. Look at the temperature of this child. Look for signs of malnutrition. Look for signs of cyanosis. In the case of very severe pneumonia, admit the child immediately. Give the child respiratory support. What do you mean by respiratory support? Might require to nebulize the child, may require to give him oxygenation. We are not talking about intubation. We are not talking, in today's COVID world, everybody talks straight away about intubation. No intubation, we are not talking about intubation. We are talking about respiratory support, which may be through giving oxygenation. Intensive monitoring is required, and antibiotic therapy. What are the antibiotics? We'll talk about it shortly. Treat the fever. How do you treat fever? Give paracetamol, sponging of the child, very important. And look for other causes of fever. As I was mentioning, in our country, we have to look for dengue, we have to look for malaria, we have to look for viral fevers. These are the things. Even today, once the COVID situation which is there, once the month of July comes on, monsoon comes on, we have to look for these three conditions: dengue, malaria, and viral fevers. And then only we can start looking for COVID also. So what is the treatment which is to be given in, we are talking about severe pneumonia. In severe pneumonia, we should give chloramphenicol intramuscularly, 25 milligrams per kg, 6 hourly for 48 hours. In case of improvement, the child can be then given oral chloramphenicol for 8 days. If the symptoms worsen, then we should think in terms of shifting the antibiotic to gentamicin or cloxacillin. This is the standard treatment which is to be given. In severe pneumonia, that was very severe pneumonia, now we talk about severe pneumonia. Severe pneumonia, again, same what we done there. Admit the child, look for respiratory support, antibiotic therapy, treat the fever, treat the wheeze, food and water intake to monitor. Same as very severe pneumonia. But we do not go in for chloramphenicol in that case. And what we talked about, cheap antibiotic, benzyl penicillin. Benzyl penicillin should be given 50,000 international units per kg, 6 hourly for 48 hours. And we can also give benzyl penicillin or ampicillin, 50 milligram per kg body weight, 6 hourly, 48 hours. Or chloramphenicol, 25 milligram per kg, 6 hourly for 48 hours. Drug of choice, benzyl penicillin. It is nowadays a neglected drug, so the action of this drug is excellent. So people don't use it. That's the reason why the body resistance, the bacilli resistance have gone down. So we are able to treat with benzyl penicillin. Please use it. In case of improvement, the child can be moved on to propane penicillin, 50,000 international units per kg, 6 hourly for 3 days, or oral ampicillin for 3 days, or oral chlorphenicol. In case of worsening, we have to look at a change of antibiotic. Pneumonia is so common in our country. We are not talking about severe pneumonia, we are not talking about very severe pneumonia. I have already told you how to differentiate between these three conditions. Now in pneumonia, home care is advised. We do not advise all pneumonia cases to be admitted to a hospital. Mother is advised to monitor the child. We give antibiotics and treat the fever. And what are the antibiotics to be given? The drug of choice which we are using in our country is cotrimoxazole. The cotrimoxazole, which is sulfamethoxazole 100 milligrams and trimethoprim 20 milligrams. Please note, sulfamethoxazole 100 milligrams, not what we use normally, that is 400 milligrams. In adults, we are using sulfamethoxazole 400 milligrams, trimethoprim 80 milligrams. This is a child dose. Sulfamethoxazole 100 milligrams, trimethoprim 20 milligrams. First line of drug. There is very few side effects. It is cheap. So what do you do in children 2 to 12 months? If you want to use tablets, you can use 2 tablets in a day. But if tablets are, it's better to use syrup for such a small child. 1 spoon of 5 ml twice a day, that should be given. 1 to 5 years, you use 3 tablets a day or 1.5 spoon twice a day. If improvement is seen, continue the antibiotic for 3 more days. If the condition worsens, change the antibiotic. Now, if there is no pneumonia, acute upper respiratory infection, no antibiotic should be given. Let me repeat. No antibiotic is required. What happens when you go to any doctor nowadays is the first thing, the child comes with a mild fever, upper respiratory infection which occur in any common cold. The first thing which is given is an antibiotic, and we develop a lot of resistance, bacterial resistance and various other, and the child, we have lots of problems which may occur. So please do not use antibiotics. Unnecessary treatment leads to development of resistance, and symptomatic treatment is sufficient for this particular child. Treatment of children under 2 months of age, pneumonia in them is always considered as being severe. Please remember that. Any child who is coming below 2 months of age has got a pneumonia, considered a severe. There is no such thing as pneumonia, severe pneumonia, very severe pneumonia in a child of less than 2 months. Any child with pneumonia is considered a severe pneumonia in children below 2 months. To be treated appropriately, immediately hospitalized. Please do not stop breastfeeding, very important. Antibiotic therapy should be prompt. So we are jumping the gun. We are not going to be generally giving a child below 2 months. We are not going to be giving what is that called? Sulfamethoxazole pyrimethamine. We are going to give that child benzylpenicillin. Okay? So, if the child is there at home, then cotrimoxazole may be started initially, because you're not going to give penicillin at home. So initially cotrimoxazole may be started, but after admission you must give benzylpenicillin for 7 days. If the child is below 7 days old, then you give it 12 hourly. 7 days to 2 months you give 6 hourly. 50,000 international units per kg, or you can give ampicillin intramuscularly 50 milligrams per kg body weight in a similar fashion. Or gentamicin. Now, if these 2 drugs are not beneficial, then you move to gentamicin. Gentamicin 2.5 milligrams per kg. In children below 7 days, you give it 12 hourly. 7 days to 2 months, you give 8 hourly. Chloramphenicol is not advised in children below 2 months. Role of antibiotics. The overuse of antibiotics we cannot overemphasize on it. Too much of antibiotics being used. Half or more of these antibiotic prescriptions are unnecessary. Viral acute respiratory infections being one of the most common reasons why the person gets infection. ARI is viral, and we give antibiotics in no use. In addition, antibiotic courses are often given, give it for 1 day, give it for 2 days. There's no use. You're developing resistance. Give it for the full course if you have to give it. Between 50 and 90% of all antibiotics are prescribed in the private sector. That's unfortunate. And you people, most of you, will be joining the private sector. So please resist. Please do not get carried away by the medical reps and use the latest antibiotics on our poor children. Poorly controlled use is associated with increased resistance of respiratory pathogens. Studies show that up to 70% of pneumococci have now become resistant to penicillin. Rational prescription and use of antibiotics should be introduced. The government has been trying a lot. They have been saying use only generic medicines. There are laid down guidelines for use of antibiotics. Every hospital has to have an antibiotic policy. All these things are available, but what happens in practice is totally different. Effectiveness of treatment. The quality and effectiveness of treatments may be compromised by a combination of family poverty, which can reduce access to full treatment. Also, there is malnutrition which may occur, which will reduce the efficacy of treatment. Approaches are necessary to ensure effective treatment for the poorer families. The biggest problem, you see, our country, we have 1.6% of the GDP being spent on health. There is, every year we do hear that we are going to increase the amount of money being spent on health. It is only because of the COVID crisis which has come that the health sector has been looked into. Otherwise, it's a very neglected sector where you have not enough money being spent on the ground. There is not enough money being spent on primary health care. We will discuss about it whenever we discuss about primary health care. Home care is very important, and that's very, very essential. Today, ASHA workers have been given the cotrimoxazole so that they can start treatment at the level of the village itself. A child who looks to be having pneumonia can be given treatment. So home care is very important for a child with pneumonia. So as we mentioned, any child who is about 2 months old and who's got pneumonia can be treated at home. Severe pneumonia, the child requires to be admitted. Child has to be fed well during the illness. If the child is less than 6 months old, breastfeeding should be continued. If he is older than 6 months old, give nutrient-rich and energy-rich foods so that the child's resistance can be built up. Child should be permitted to eat as much as he wants. If the child is not eating well because of a blocked nose, it should be cleared. And basically, we're looking at giving the child one extra meal a day, so that especially the malnourished children should be given some extra. We have where can the malnourished child get extra meal from if the parents do not have finances? We have what is called the Anganwadi, from where food is given free to children, and so we must utilize these facilities at the Anganwadi. The parents should be guided that food should be collected from the Anganwadi for these children, and they should be given a nutritious diet. Enough fluid should be given to the child, and milk, water, fresh juices, rice water, homemade soups, these are things which we can use. What are approaches for prevention of ARI? We should look at general measures and immunization. We should think in terms of improved living conditions, very difficult. Well, that is the job of the government to do. We have to ensure better nutrition. Again, the job of the government has to pitch in with improved nutritional facilities, provide nutrition to the malnourished children as well as the population. improved ventilation in the, you see, overcrowding and poor ventilated conditions result in transmission of the disease. So we should look in terms of improved ventilation, which sometimes is very difficult in our circumstances. Better mother and child care should be given, and immunization is a very important component. As I mentioned, what are the two things which are most the two commonest causes of pneumonia? Hemophilus influenza. Do we give Hemophilus influenza vaccine to the child? In Telangana, do we give Hemophilus influenza vaccine to the child? Well, it is yes. We give a pentavalent vaccine. Can you point out what is there in the pentavalent? Five things in pentavalent vaccine: D, P, T, Hemophilus influenza, and hepatitis B. So we have got 5 things which are given, pentavalent vaccine, given to the child at what age? 6, 10, 14 weeks, which is there. And then boosters can be given of this particular thing later on. Okay. Now, other things which can be given to the child, which are not being given in our country, is as a routine, is against pneumococci. We can have a polyvalent polysaccharide vaccine, which is given the conjugate vaccine, which today is now being changed to, we are going to have a different type of vaccine which is coming up. This vaccine is likely to be introduced into the expanded program of immunization shortly. Of course, we definitely give measles vaccination, given at what age? 9 months. Booster to be given at 18 months. And then influenza vaccine, which is now quadrivalent vaccine, which can be given, but it is not a part of the government's national immunization schedule. These are the things which can be given. Training and supporting community health workers to provide diagnosis and treatment and support of home care being carried out. We have IMNCI in place. Training is being given to ASHA workers as well as to the sub-center as well as to the Anganwadi workers in early detection of ARI and their treatment. Mechanism for implementing the concept of household treatment of pneumonia. This is a thing which is being carried out. As I mentioned, ASHA workers are today being trained who can assess the child at the ground level itself. That's all that we have today from my side. Please revise this chapter. There are more things in this chapter, but we have a limited time, so we have to complete this in this particular scheduled time. Please read it up in detail. Very important topic, acute respiratory infection. Whenever you start practicing, you will land up with cases coming to your OPD. And just because you have not seen acute respiratory infection in the hospital does not mean that you will not get a case in the OPD. So please remember how to treat it. And please read up about IMNCI, which we may discuss, which someone else will discuss with you. Thank you.
So that you will then be able to ask questions.